Hello, I'm Dr. Ira Nash. Welcome to Well Said. Hair. It's something many of us take for granted until we start noticing it in the shower drain or on our pillow. Hair loss affects millions of people across all ages and genders, and while it's often brushed off as cosmetic, it can take a real toll on one's self-esteem and emotional well-being. What actually causes our hair to fall out, and what can we realistically do about it, if anything at all? To help answer those and other questions, I'm joined today by Dr. Pooja Shah. Dr. Shah is an assistant professor of dermatology at the Zucker School of Medicine at Hofstra, Northwell, and she's the director of dermatology at the Katz Institute for Women's Health at Northwell Health. Pooja, welcome to Well Said.
Thank you, Ira.
So let's start with some basics about normal hair growth. Can you give us a quick lesson on how hair normally grows?
The hair cycle usually involves three major phases. There's the growth phase, which is known as the anagen phase. There's the telogen phase, which is the shedding phase, and then there's the resting phase, which is the catagen phase. So at any given point in time on a normal scalp, about 80 to 90% of our hairs are in the growth phase, and about 10 to 15% of our hairs are in the shedding phase or the telogen phase. That percent that's left behind, about 2 to 5%, can be in the catagen or the resting phase where they're essentially in transit. At any given point, there's always a major portion of our scalp that's in the growth phase, but there's also a certain percent of our hairs that are always shedding. So I always tell my patients that it's normal to shed hair on a day-to-day basis.
Are those in different locations or different kinds of hair follicles, or this is just sort of a general, all over the place, this is all going on?
It's definitely all over the place. It's very haphazard. Each follicle is going on its own cycle. It happens all over the place on the scalp. So in some people, it may be more localized versus more diffuse.
It's normal to lose some hair every day is what you're saying.
Yeah, I actually tell my patients it's normal to lose up to 100 to 200 hairs a day. The variation can definitely be different for different people.
Yeah, I've never thought about it in terms of numbers of hairs. Do you have patients who actually try to count?
You know, I actually have patients who come in with their Ziploc bags full of hair. Like, look at this bag of hair that I'm shedding every day. And oftentimes it's nice to have a number because I think it gives them a reference point as to where they can just gauge where they stand in the normal variation of hair loss.
Yeah, we started, I guess, implicitly talking about hair on the head.
Yeah.
But I just want to make sure we at least acknowledge that hair grows elsewhere.
Right.
And we can come back to the sort of, I guess, more basic concerns about losing the hair on your head. But is this different, what you just went through, if we're talking about body hair or pubic hair or hair elsewhere?
Yeah, I mean, hair loss can happen in any part of the body, including your eyebrows. You can get hair loss in your armpits and the groin. You know, for example, lupus can cause hair loss anywhere, or there's some other autoimmune hair loss conditions where you can get hair loss in other parts of the body besides the scalp.
Is that same sort of normal cycle of growth and shedding and regeneration happening all over the body?
No, I think that really is more specific to the scalp, that cycle that I spoke about. The hair loss that happens in other parts of the body, I think there's a lot more that goes into it. It's very complex to really fully understand.
Yeah.
But it's usually more of the autoimmune conditions where you see that, including the other parts of the body.
Is it fair to say that hair loss outside the scalp is always abnormal? I mean, we shouldn't be shedding hair elsewhere?
Not always. I mean, I think in a lot of my older patients, like, they tend to have less hair growth on their lower extremities. I do think that with age, hair thinning is a very common phenomenon, so it's not always considered abnormal. So I guess it depends on which stage of life you're in. Okay.
So let's go back to hair on the head.
Yeah.
So talk us through different common patterns of hair loss.
So there's, many different groups of hair loss or patterns of hair loss. There's the genetically driven hair loss, or what we call androgenetic pattern hair loss. That's the most common that we see in men and women with age. Then there's telogen effluvium, which is more...
That's a big word. What does that mean?
Yes, so that is basically excess hair shedding. So that's when there's an increase in the percent of hairs in the shedding phase, and that can happen in many different situations. For example, postpartum, so after giving birth, after a big stressor in your life, after having a major surgery. So any big stressor to the body can result in this telogen effluvium months after the stressor.
And that's a more generalized hair loss. It's not in a particular pattern. Is that what you're saying?
Most people really just notice the hair loss on the scalp. I think people are
No. I meant, but in the scalp,
Yes.
it's not in a particular pattern
It's
on the
not.
scalp. It's like all over the head.
Yes, it's more diffuse.
Yeah.
Then we have an autoimmune type of hair loss like alopecia areata, which could be localized on the scalp, but it could also be generalized. It could also be involving the entire body, which is otherwise known as alopecia totalis or alopecia universalis. Yeah, so I think those are the big categories of patterns, different patterns of hair loss.
So you mentioned the first one was the sort of typical male pattern baldness, and you said that's genetically driven?
It is. So genetics plays a huge role, but I do think, your lifestyle, your diet, your nutrition, stress affects everything. But I do think with the male and the female pattern hair loss, genetics plays a huge role.
I don't know if this is an old wives' tale, but somebody told me years ago that the person you should look to if you're a man to figure out if you're going to go bald is like your maternal grandfather.
Right.
Is there anything to that, or is it more complicated
So
than
that is the saying, and I think in the books we're taught definitely there's a component of the maternal side that gets passed on, but in real practice I feel that it's not very driven by the mom side or the dad side. I really just ask about the family history, and if there's a strong family history I tend to see it in the patients as well.
Okay. When we're talking about male pattern baldness, just describe exactly what we're talking about. What is that pattern?
Yeah, so you would see thinning in the front, so your frontal hairline, and then more in the back towards the vertex of the scalp.
Okay.
So that's more for male pattern baldness.
As that progresses, those sort of meet in the middle.
Right.
Okay.
And then, you get diffuse hair loss.
Okay. What about sort of gradual non-disease related hair loss in women? I mean, you see women who look like they're going bald like men typically do. What's going on there?
You mean the female pattern balding?
Well, yeah, I guess it is slightly different. So what is the female pattern?
Right. So female pattern is a little different than male pattern. You tend to see more widening of the part in women, and it's more of a diffuse thinning rather than, localized to certain parts of the scalp. And then, there's a lot of other autoimmune hair loss conditions that we see in women. So I forgot to mention, another big pattern or type of hair loss, which is scarring alopecia. And there's a lot to be really looked into and researched in this specific category because we tend to see that a lot in my African American patients. They have scarring hair loss. You wonder if that has to do with, their hairstyles that they do or chemical treatments, perms. So a lot of the relaxer treatments, you're putting a lot of pressure on the hair follicle, and that can lead to scarring over time. There's also autoimmune conditions like lupus that can cause scarring alopecia. In women, you can also see non-scarring types of alopecia that are autoimmune driven, for example, alopecia areata, which also can be seen in men. Women definitely have a lot more autoimmune driven processes that can lead to hair loss besides their genetic predisposition.
Yeah, we've talked about autoimmune diseases on this show in the past and have made note of the fact that women seem to be more at risk for autoimmune conditions of all sorts than men. I'm not going to ask you to explain that because I don't think anybody really understands that. But say a little bit more about how autoimmune disorders affect the scalp and hair.
For example, specifically in alopecia areata, you get whatever inflammation is going on in that autoimmune condition. It affects the hair follicle very locally, and it essentially causes the hair to go into the shedding phase quickly. So you get this like overnight shedding or overnight balding. Patients will come in saying like, oh, I woke up with a bald patch on my scalp. It's such a quick process, and I think you just get this increased inflammation or inflammatory cells locally at the hair follicle itself. Whenever you have an autoimmune-driven process, there's increased cortisol levels, increased stressors, and that again can shift the hair cycle, cause the hair follicle to go from the growth phase to the shedding phase.
Okay. And just to be clear, when we're talking about autoimmune, what we're saying is the body's own natural defenses have somehow gotten off track and are attacking
our own
our own cells instead of foreign
Right.
bacteria and viruses and stuff like that.
Yeah.
Yeah. Are there specific autoimmune diseases that are more associated with hair loss than others? You mentioned lupus. What about some others?
Alopecia areata itself is considered an autoimmune condition. Lupus is one of them. Thyroid disease definitely plays a huge role in the hair. Hypothyroidism and hyperthyroidism, it significantly affects hair growth, hair loss. So those are some main common ones that I see. Then anemia, so pernicious anemia can also lead to hair loss. So that's where the nutrition plays a role. Iron deficiency anemia, that again, that's not autoimmune, but you tend to see it in women who have these autoimmune predispositions.
You mentioned stress as a common precursor for hair loss. Is the connection between the two understood? How does stress lead to hair loss?
I really think the biggest connection here is stress affects the hair growth cycle. It really shifts that percent of hairs that are in the growth phase into the shedding phase. That's why people say, well, I've had a huge stressor. I had a death in the family, or I just went through a major surgery, and months after, here I am shedding like tons of hair.
It can be that precise.
Yes.
where people can identify a life event?
Yes.
Huh.
Yeah. A lot of times patients come in and they say, well, I'm not stressed right now, but and I say, what about in the last 6 months? I will always find something that had happened that can trigger it. And sometimes patients can't particularly pinpoint. If I were to go into their homes and live with them, I'm sure I could find an inciting event.
Yeah, although I guess if you ask most people if they've had a stressful event in the last 6 months, I wonder how many people would say, no, it's all been great.
Yeah, I think after COVID, everyone's stressed all the time. But
Right. Actually, that brings up another question, not related directly to hair loss, but to stress and hair. You hear these stories about people getting a shock of white hair, or their hair color changes abruptly after a stressful event in their lives. Is that a real thing?
Yeah, that is a real thing. So the cells that are in your hair follicle that produce the pigment of your hair, in a stressful event, those cells actually do get affected, and they're not, you can get premature graying because of stress and high increased cortisol levels. So there's definitely some localized effect that's going on the scalp, which is leading to premature graying, hair loss, hair thinning. And sometimes it's hard to recover from that, to go, to reverse it. It's not easy.
Yeah. Is there a relationship between graying and hair loss? Our listeners can't see us. I'm pretty gray, but I have most of my hair.
Yeah, I was going to say, I don't think there's a clear connection, because I see a lot of patients who have graying but a great full head of hair, and then I see patients with dark hairs and a lot of thinning. So I don't know if there's a true connection there.
I just want to circle back also to this issue that you raised about hormones, normal hormones that we all have, and hair loss. So what is the role of normal male hormones in hair loss? So we'll start with men and then go on to women.
In men, it's testosterone plays a huge role. So, there's I think it would be easy to explain if I start with women.
Okay.
So, for example, in menopause, as women age, their estrogen levels drop, and their progesterone levels go up, which mimics testosterone, and that's the whole idea behind thinning in women.
Okay.
Because testosterone affects the hair follicle locally, and in women, progesterone that mimics testosterone. And in men already have high testosterone to begin with, so that itself can also lead to the male pattern balding.
Okay, so that kind of answers both questions. So testosterone itself seems to promote balding?
Mm-hmm. And that's why one of the treatments that we use in male pattern hair loss is finasteride, or oral finasteride, which essentially blocks the effect of the testosterone at the receptor level.
Oh, interesting. All right, we'll get to treatments in a second, but I want to also go back to what you were saying about lifestyle and kind of how we treat our hair as potential risk factors for hair loss. So before we get to actual hair treatments, speak more generally about lifestyle, how we go through the world.
I mentioned the first three categories, which we don't really have much control over. So our patterned hair loss, that's our androgenetic alopecia, our telogen effluvium, or our autoimmune-driven processes. We don't have much control over it, as much as we would like to. The scarring alopecia especially, lifestyle plays a huge role. The way we treat our hair, our hair care practices, a lot of those things, overheating our hair, or using straighteners with excess heat, those things can really damage the hair in the long run. And any new hair follicles that are trying to recover, or any new hairs that are trying to grow in, the more chemical treatments that we do, the more heat we give them, we essentially damage that hair follicle. And over time, it just gets harder and harder to recover from that. It's also important to know that as we get older, our hair cycle actually shortens. As we get older, we always say, oh, my hair doesn't grow as long as it used to, because it's just impossible biologically. So our hair cycle shortens as we get older. It is really hard to have that same length of hair that we were able to back in college or high school.
Yeah. What we do to our hair, what we put on our scalp matters. Is there any danger to washing your hair too much, not washing your hair enough? What about that?
No, I think, the biggest mistake that my patients make when they have this hair shedding or increased hair loss is they don't wash their hair enough, because they are very afraid to see the hair in the shower drain.
Yeah, they get traumatized by that.
But what happens there is that you end up actually letting grease or, the buildup sit on your scalp, and then that leads to more hair loss.
Okay.
So one of the things I always say is you can't, you have to wash your hair as much as your hair needs washing, whether that's once a week for some people or 3 times a week for some people. That can really vary individual by individual.
Yeah. And outside of hair care, what other lifestyle practices seem to make a difference in hair loss?
I think nutrition, so your diet, makes a big difference. Vitamin D deficiencies can really affect your hair growth. There's a lot of vitamin D receptors on the scalp. So when your vitamin D levels are low, it's a big reason for hair shedding. Iron intake as well. I think exercise. There's so much data that exercise helps reduce stress levels or cortisol levels, and that indirectly affects your hair as well.
It's so funny that you mentioned that, because we do shows on all kinds of different subjects, and it just seems like it doesn't matter what we're talking about: heart disease, brain health, hair loss. Everyone recommends exercise. So I'm glad you brought that up. But it's fascinating to me that exercise should have an effect on your hair. But I guess it does. Good to know.
You need blood flow everywhere.
So let's talk about the sort of evaluation and management of hair loss. So at what point should somebody say, gee, this is more than I should be losing in terms of what I see in the drain or on my hairbrush? What's an appropriate trigger for a patient to follow to seek medical evaluation?
Going on that framework of 100 to 200 hairs a day, if you see excess amount of hair on your pillow when you wake up, if you see an excess amount of hair in your house just shedding or in your shower drain, that's definitely a valid reason to come in to a dermatologist to seek help and make sure there's nothing that can be done or interventions that can be done to help slow down that shedding. Another thing that I always mention, itch on the scalp or excess flaking on the scalp, pain on the scalp, those are all potential reasons that could be a sign of something going on that could be treated. So any of these symptoms, I think, are all a reason to come in.
And I guess people would also come if they notice just like a localized patch of hair loss, right?
Right.
And so somebody comes to you and says, hey, I've noticed over the last, few weeks or months, more hair in the brush, more hair in the drain. How do you evaluate that patient to see what's going on?
Sure. So if someone's coming in, the number one thing is the exam. I look through the scalp. I look for signs of inflammation, whether there's redness on the scalp, whether there's increased scale on the scalp. And then we do what's called a tug test or a pull test. It's a very gentle test.
You pull on somebody's hair.
Yeah, and it's it can really be a little nerve-wracking for a patient because like, wow, I'm already losing hair, and here the doctor's here like pulling on my
out
hair.
More hair. Right.
But it's called a pull test, and if it's a positive pull test, that's a sign of that telogen effluvium that I was talking about.
So you actually tug on the hair and just get a sense of whether it has a normal resistance.
Yes.
Or it just comes out.
And during COVID, it was really mind-boggling the amount of patients that I saw with positive pull tests, like very bad positive pull tests.
Meaning what in your mind?
I would literally, patient would be sitting in the chair and I would see a clump of hair behind them.
Wow.
And that's not normal.
And what do you think that was about?
I think COVID. COVID was the stressor.
Just the stress of it all.
Yeah. And, we know that with COVID, there was so much increase in inflammation in the body in many different ways. And hair was one of them.
Now, I'm assuming that you're also looking for some of those specific things that you mentioned that could be causing hair loss, vitamin deficiency, anemia, autoimmune disease, et cetera, et cetera. So I'm going to put those to the side thinking like, well, if you find that, that's what you're going to treat.
Right.
And then the hair will recover, hopefully, as a positive byproduct of treating the underlying condition. But for those other things, stress-related hair loss or just genetic hair loss, if you don't find a specific cause, then what do you tell the patient in terms of their options for either halting the hair loss or actually regrowing hair?
The number one thing is setting the expectation. So once the pattern hair loss starts, the androgenetic, it's chronic. Treatment is basically chronic as well. You have to essentially keep catching up with your genetically predisposition to hair
So it's not like you treat it, it gets better, and then
you're done.
You're done. No, this is constant maintenance.
Right.
Like treating high blood pressure or something like that. Okay.
Yeah. With treatment, the number one treatment is topical minoxidil. So it is FDA approved. And usually I recommend 5% minoxidil, which is available over the counter. There's men's 5% and women's 5%.
Are they different?
They are not different, but there's a pink tax on the women's 5%.
Yeah,
so
I'm not surprised. Okay.
So I would say buy the men's 5%. You could go to Costco or BJ's and buy it in bulk.
And doesn't require a prescription?
Nope.
Okay. How effective is that?
It works really well as long as you're consistent with it. But it doesn't work within a month. I tell patients you have to use it minimum of 6 months before you see any results, because it essentially follows the hair cycle growth and it helps transition those hairs into the anagen or growth phase. So that takes time, and it takes several cycles to see that because the hair grows very slowly.
Yeah. And is it the case that you have to start that at a particular severity of hair loss? I imagine, like, if somebody's been bald for 20 years, I imagine the minoxidil is not going to be as effective as somebody who's, like, noticing that their hair is starting to thin.
I think it's more effective when you start early. And that way you can actually try to recover and get some hair growth to mask the thinning that you see. When someone's really bald, then we're looking into transplants. Then I say don't waste your time. You should just get a hair transplant.
So we're talking about minoxidil being a treatment to kind of arrest the progression and allow for regrowth earlier on.
So minoxidil really helps more with the hair growth, whereas finasteride, which is an oral medication, it's a prescription that blocks the effect of the testosterone at the receptor level. That is what I will do to really more halt the progression. So specifically in a male.
Okay.
In a female, we can also recommend minoxidil topically or orally. Now we have oral minoxidil, which is a prescription. And then finasteride, I wouldn't use in a female who's childbearing age because it's contraindicated. But you can use spironolactone until they decide that they want to get pregnant. And spironolactone has a similar effect. It can block the effect of testosterone in someone who has very prominent female pattern hair loss.
And side effects of these medications?
With finasteride, there is this condition. There is this condition called post-finasteride syndrome. Very rare side effect, but sometimes patients can. There's reports of sexual dysfunction. Again, out of the many patients that I've prescribed it to, maybe one or two have had this, and they stopped it, and their side effects reversed. But in the cases out there, there is a potential for this being a permanent side effect. So again, I think it's really rare and it doesn't stop me from prescribing, but I do like to have that conversation with patients just so that they're aware of what they're signing up for.
Yeah. We had a show not long ago where I was interviewing a urologist around urinary tract symptoms, especially in men, and finasteride is used to help shrink the prostate and help men with their urinary problems. Are you giving it at the same kind of dose that?
We're usually doing I'm doing 1 milligrams daily, so a lower dose.
Lower dose.
Yeah.
Yeah. Okay. There's a ton of stuff over the counter that's available that you see touted all the time, natural remedies,
Yeah.
herb supplements, blah, blah, blah. Does any of that stuff work?
Rosemary oil, there are studies that have shown that it can be comparable to a lower percent of minoxidil. It's not as great as 5% topical minoxidil, but if someone who's opposed to using quote-unquote chemicals, rosemary oil is an option, but you have to be wary of potential irritation to it. So I always recommend diluting it in another kind of base oil like coconut oil or mineral oil before applying it. Other things that are over the counter, there's the low-level light therapy, so the hair laser combs or the laser caps. I think they work well in conjunction with minoxidil, not necessarily on their own, but again, some patients just do it and they think it works really well.
Yeah.
It's just cost prohibitive for some.
Yeah, I can imagine. For people who have patchy hair loss associated with some autoimmune condition or maybe an autoimmune condition kind of isolated to their scalp, what about sort of focal topical treatment?
So those patients, usually they come in, I'll prescribe a topical steroid solution to stop the inflammation locally. And we often do steroid injections onto the bald spots of the scalp because it's very hard for topical medication to penetrate the scalp. So the more we can just really deliver the medication straight into the hair follicle, it's very effective and they will get the hair back.
Is that something you can identify just by the appearance, or do you need to do a biopsy? How do you assess?
Oftentimes you can, just based on clinical exam, you can tell if it's a non-scarring type of hair loss. If on exam I see that there's any evidence of scarring, I often will biopsy it because there's many different causes for scarring alopecia, lupus being one of them, or traction alopecia from hairstyle, doing tight hairstyles, or central centrifugal cicatricial alopecia, which is more common in African Americans.
What is that?
That's a type of scarring hair loss that you can see related to really, perms, relaxer treatments, chemical. But there's a lot of research being done on it where they're really looking into seeing, is there a genetic predisposition to this type of scarring hair loss, especially in patients who don't do these harsh hair practices, then why are they getting it? So I think there's a lot to be figured out in this arena.
Yeah. So if you were to give some advice to the general public about sort of protecting their hair from future hair loss, what would that be?
I would say number one is to practice gentle hair care.
Gentle hair care.
Gentle hair care. So using a shampoo that's not too harsh. Never putting conditioner on your scalp itself. The conditioner is only meant for the hair.
Okay.
That's something that patients often do. The conditioner is just meant for the hair strands, not the scalp. Making sure that you're up to date with your primary care in terms of your annual blood work. So vitamin D levels, your iron, your thyroid. Those are some major things that I have them check once a year. When in doubt, seek a dermatologist.
Yeah. If people want to get more information without coming to see you,
yes.
Is there a place you would send them for high quality information about some of the things we've talked about?
Yeah. I mean, the American Academy of Dermatology has a lot of resources for patients with hair loss. So their website is great. That's aad.org. A lot of these, our podcast right here.
Yeah.
And a lot of webinars that are driven by physicians or medical practitioners who are experts in this.
Great. All right. Well, Dr. Pooja Shah, thank you so much.
Thank you. Thanks for having me.
I'd also like to thank our editor, Edward Lee, and our audio engineer, John Mullen. For more information about this particular program and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.